Good evening, everyone. It's Dr. Galvin with today's coronavirus update. I'm trying to see how many different spots in this one little office I can shoot this video from. So this is a one wall I haven't done yet. Numbers today: 1.3 million cases worldwide, 74,000 deaths, 275,000 recoveries in the U.S. as of this afternoon. 352,000 cases, 10,000 plus deaths, 19,000 recovered. In my state, North Carolina, 2,870 cases, 33 deaths. They don't report how many people have recovered. So, what's going on? We keep hearing about the peak. Is the peak here? People keep asking me what's going on in the hospital. It's not as bad as, locally at least, as bad as we'd hoped it would be at this point. We think that the peak for here is probably out a few more weeks. We're certainly seeing cases. I think we've had 35 plus cases in the emergency department in the last week or so. A few of those people have ended up intubated, less than before. A few of those people have unfortunately died. But the good news is we're not seeing quite the volume of sick patients that we were fearful that would just overwhelm and take over everything. Now that doesn't mean that it's not coming, but so far it looks like maybe the social distancing is having an effect. There's some interesting information about intubations, and one of the reasons that we're not doing as many may be because there's some interesting information that's coming out. And you got to understand that they don't call medical practice for nothing. Very often in medicine, we don't know. We base our current actions on past experience. And when presented with a new set of realities, we adapt and overcome. And what that means is treatments that we start initially with thinking of the right thing may subsequently turn out to be the wrong thing. And intubation is one of the things that we're starting to restudy in the emergency medicine literature amongst the emergency physicians, critical care physicians, the folks who are actually on the front line taking care of these really, really sick patients. And what we're finding is that maybe that virus is having an effect on the hemoglobin molecule itself, causing problems with oxygenation. But maybe what's happening is not so much a primary lung problem. So we're now, there's mounting evidence and mounting talk within the profession that we should be careful about who we intubate. We initially would rush to intubate early because people would tire out and they would end up doing a crash intubation, which is very dangerous. And the thought initially was intubate these people early, get their airway protected. But because of the nature of the disease, in order to keep oxygen levels where they need to be, we have to use a lot of pressure on the lungs to keep them inflated. And we're now thinking that maybe that pressure, the PEEP in the ventilator, may be causing more pulmonary damage and causing part of the problem. So now we're starting to talk about letting people have permissive hypoxia, meaning that if someone's oxygen saturations are very, very low, where they would normally make us very nervous and we would rush to intubate, if the patient is awake and comfortable and is not tiring out, now the thought is maybe we're going to hold off and we're going to watch that person, and maybe we can avoid putting them on the vent because we know the mortality rate on the vent is very, very high. The mortality rate, if we can keep you off the vent, is actually pretty good. So things are changing every day. I get a million questions a day about, why aren't you using these life-saving drugs, azithromycin, chloroquine? Why are we not using these drugs? Well, we are, but we need to talk about the data here. And I know President Trump keeps pitching it, Dr. Oz keeps pitching it, but actual scientists are saying, hold on a second. The data's been mixed. There was an initial study out of France. It was very flawed that showed clearing of the virus when given hydroxychloroquine and some other and azithromycin together. However, there was another study that was done, a short time later in France also that could not reproduce it. There was another study in China that similarly showed no improvement with these drugs. And then another study that showed that maybe a slight improvement in terms of shortening the duration of disease for mild cases. So it may be a little bit like Tamiflu ultimately. We give people Tamiflu not to cure the flu, but to shorten the course of it a little bit. What we don't really know, because we don't have good studies, is we don't know if it actually is a cure, which we don't think it is by data and everything else we've seen. It doesn't seem to be a cure. And the other thing it doesn't seem to be helping is those sick patients, because they're getting those drugs and they're not improving. But maybe the role is when you first get those symptoms, if you take one of those drugs or a combination, it may shorten the duration. Until we have good science, it's hard to say. Remember, observation does not equate to causation. And that's what what you see in the news. Oh, we saw this, it must mean that. No, you can't do that. The only way you can really make that conclusion and make that mental jump is to actually have a group that you do something for and another group that you don't do it for, and you compare the results. So I could see, 3 pink cars drive by my house today and my water tank springs a leak. It doesn't mean that pink cars cause my water tank to leak. It's just happened to be a coincidence. And so until we do an experiment where we have, 3 pink cars drive by my house, and then in another neighborhood, 3 pink cars drive by another house, and see what happens. If the water tank leaks on both places, maybe we got something. But if it doesn't, maybe we don't. So we have to be a little bit careful about that. I think that there was another question asked about blood type in the comments yesterday. There was a very small study that came out of China that showed a little higher rate of infection. People had blood type A versus type O. And unfortunately, poor study, very small numbers, and was published in a non-peer reviewed journal, meaning that because everything's so new, many of these studies are being published without being peer reviewed, meaning that they're preliminary. What does peer review say? Is that, if you got some idea, you give it to a bunch of skeptical people like me, and we're going to tear it apart. And if we tear it apart and it still seems to, everything seems to make sense, and we all sign off on it, then it gets published. Meaning that your peers review it, and if they agree with your conclusions, then it's reasonable to publish. The other question is the death rate. I keep hearing people say we're over-reporting the death rate, we're under-reporting the death rate. I'm hoping that we're over-reporting it. And the reason is that really, if you look at how those things are calculated, it's the total number of patients that are admitted to the hospital versus the death rate, or the total number of patients that have positive tests. So, that denominator, the lower number, is limited in terms of people who have just been diagnosed. But we know, as we've talked about many times before, most people are going to get this and not have really bad symptoms at all. So that denominator is probably a lot bigger than the numerator up on top, meaning that the death rate may be much lower than what we're seeing. And I think we talked about it a few maybe 5-6 days ago. I think I talked about the actual mortality rate being probably 0.2%, not 1 to 4%, because when you take into account all the people that actually probably have it and aren't getting tested, that's something else. The antibody testing, it looks like it's coming. I just got a notice from our hospital that apparently we're going to have an antibody test available sometime in the next couple of weeks. I don't know how available it's going to be, how it's going to be used, but that antibody test will tell people whether or not they got infected or not previously and have antibodies to it, which would be very helpful in a healthcare setting for us. If we knew one of the docs had been exposed, and we have an area of the emergency room now set aside just for COVID patients, well, it would make sense to have that person work there because they're already immune, as opposed to somebody who isn't immune working there like we do it now. A couple good news. I mentioned Bill Gates yesterday. A lot of hate for that. I guess people don't like Bill Gates, but to back up what he said, there's another model out there of mortality that shows that the number of projected fatalities may be a lot lower than what has been reported previously. So that's good news. We're not gonna yell at good news. One other interesting fact: a tiger at the Bronx Zoo tested positive for the virus. Didn't get sick. We don't know if tigers can give the virus or not. So my advice for the day is I would practice pretty extreme social distancing from all tigers that you may come in contact with. Anyway, we'll be back tomorrow. We are going to do a Facebook Live. We're going to try something new this week. Later in the week, I haven't decided, maybe Thursday. Leave your questions below. I'm trying to answer them as they come across. Stay safe. Take care of yourselves. Take care of your families. Take care of everybody else. And I will talk to you tomorrow.